name is Kelsey Dillenburg, and I'll be presenting a patient that came in through the ER. This is RK. She is a 15-month-old female brought to the ER with a chief complaint of vomiting and diarrhea for 2 days. Her mother describes the emesis as tan and then clear, describes the stools as liquid with a foul odor with no blood or mucus in the stool. She reports the child is unable to keep anything down, vomiting after every feeding, even Pedialyte. She has had 7 episodes of diarrhea and 3 episodes of vomiting each within the past 2 days. Her mother also reports she is not feeding well. Her activity level is significantly decreased. She seems very weak and sleepy. She has had a decreased amount of wet diapers. She attempted home daycare but has not attended within the past 3 days. Past medical history is non-significant, lives at home with parents and her 4-year-old brother. Surgical history is none. Review of symptoms, she is positive for vomiting, diarrhea, low-grade fever. Also, brother had mild diarrhea a week ago. Appendicitis is also what I'm thinking, positive for abdominal pain. However, the pain is not all over, the pain is all over, not in any one spot. Negative for any high fever. She's negative for seizures or altered mental status. Negative for lumps in the abdomen or bloody mucousy stool. Negative for any recent infections, URIs, or cold symptoms. Physical exam, her vital signs now are 100.2. Heart rate is temperature, heart rate 160, respiratory rate 32, blood pressure 88/40, O2 is 99% on room air. Her weight is 11 kilograms. General patient is awake, appears somewhat sleepy, being held by mom. Head atraumatic, normocephalic, depressed anterior fontanelle, no meningeal signs. Eyes, no icterus, no discharge, no conjunctivitis. Her ears, no discharge. Tympanic membranes are without erythema, with good light reflex bilaterally. Nose, no discharge. Throat, dry, cracked lips, moist oral mucosa, however. No exudates, her uvula is midline. Neck, no lymphadenopathy, no nuchal rigidity noted. Cardiovascular, regular rate and rhythm. This one, S2, no murmurs, no gallops, no rubs, no thrills, no heaves palpated. Femoral pulses are bounding with a capillary refill equal to 3 seconds. Her respirations are clear to auscultation bilaterally, no wheezes, crackles, or rhonchi noted, no retractions. Abdomen is soft, non-tender, non-distended. Bowel sounds are hyperactive. No hepatosplenomegaly, no masses felt on palpation. There is some tenderness to palpation all over. GU, normal appearing genitalia, Tanner stage 1. As her diaper is taken off, patient has a large liquid stool that is yellow-brown in color with a significantly foul odor. No blood or mucus noted in the stool. Her extremities are warm with symmetric tone. Muscle development and strength is normal. Neuro, no atrophy, moves all extremities equally. Her reflexes are 2+ at patella, ankle, and biceps. Her skin is pale and slightly mottled. Assessment, I am concerned the patient is having an acute gastroenteritis episode and is moderately severely dehydrated. She does have some abdominal pain, but the pain is not located anywhere specific, and she does not have any high fever. So this is not consistent with appendicitis, but some lab work should be done to rule this out. She also could have a toxic ingestion, but she has had no episodes of seizing, no altered mental status or changes that indicate this diagnosis, making AGE more likely. The patient has had no abnormal lumps palpated in the abdomen or blood or jelly-like stools, making intussusception less likely. Since the patient has had no recent history of URIs or cold symptoms, a viral syndrome is also unlikely. For the treatment, I think we should obtain a CBC to rule out infection, BMP to check for electrolyte imbalances and assess hydration status, and a blood glucose to determine the need for glucose. Rehydrate patient with 20 mL per kilogram of NS over an hour, times 1 dose for now, and then maintenance fluids of D5 half NS at 65 mL per hour. And then after the child voids, we can add 20 mL equivalents of KCl per liter. We should also admit to the pediatric unit to further evaluate.
Okay, good. Perfect.
All right.
Thank you.
Thank you.